So today I would like to first of all introduce myself. I'm Mary Yates. I'm a nurse consultant at South London and Maudsley NHS Foundation Trust, and I provide the leadership for the smoke-free programme there. I want to acknowledge and give thanks to all the patients that I've worked with over the years and from whom I've learned so much, but also to my colleagues, and particularly to my colleague Dr. Debbie Robson, who's been my teacher down through the last decade. So today I'm going to focus on speaking to you about restrictive practices and how we've tried to work around implementing the smoke-free policies while paying attention to be as least restrictive as we possibly can. I'm going to talk about how our smoke-free journey has evolved over the last decade or so, what we've learned, some of the key things, and how it's going now, and particularly tell you a little bit about our developments in relation to our integrated model that we are now working with. So I always begin my talks by acknowledging the failures on my part and on the part of some of my colleagues who sadly worked in an environment where we undermined health every day by helping people and enabling them to smoke in our care. So shame on me for being part of an NHS where we actively helped people to smoke, and I used to myself personally purchase cigarettes for patients and make sure that I did everything I could to help people to develop preventable disease and to die young. Thankfully, about a decade ago, after a conversation with a patient, I realised the errors of my ways, and I've been trying ever since to change direction and to make sure that we do whatever we can to make it easier for people not to smoke. Now, a large part of my journey has been about trying to change the hearts and minds of people that I work with. And I know that's a difficult thing to do. And I've, in the beginning, thought, I'm not sure that we can do this because it is quite a significant shift in thinking. I think when you're starting out on this smoke-free journey, one of the most important things to do is to just start having conversations and listening to people. And making sure that you start to think about holding the space for these conversations and thinking about why a smoke-free policy is an important part of any modern mental health care service. In the early conversations, I used to use the EPE model. If you're not familiar with that, that stands for eliciting what people already know about tobacco dependence treatments. And you'll be surprised because most smokers have already repeatedly tried to quit. So just having a listen to that and hearing about what their experiences of trying already to cut down or quit are really important. And then asking for permission to share some of your own knowledge about smoking and quitting, and then eliciting from them what sense they make of that and how that might change their view now. So all of those early conversations are really important, and making sure that we're not coming in and telling people what to do, but we're starting from a position where we're really respectful to other people's experience. As we developed our confidence and our skills, it's really important sometimes to then show people what to do. So showing people, you know, things like, for example, how to start having conversations with smokers, how to do carbon monoxide tests, how to record this information. We've got to roll our sleeves up and be in and around and amongst our doctors and nurses and colleagues if we want them to do this work, show them how to do it. And then make it easier for them to incorporate tobacco dependence treatments into their very busy schedules. Everyone's under pressure, but if we can make it an integral part of their routine and find ways to embed it in the practice, then that will make it more achievable for everyone. When people get give them a pat on the back, tell them how well they're doing, and make sure that you celebrate success by, you know, rewarding people, giving them acknowledgement, highlighting their success wherever you can. Now, there are huge changes to make, and I think it's important to recognize that when we are trying to make this huge, significant change in culture, there are lots of different elements to it, and we need to break each one down and have a group focused on working on each one in return. First of all, thinking about education and training. So it's impossible to make progress unless you have a competent workforce. So do focus on how you're going to train and educate all the different elements of the workforce. And thinking that, you know, everyone needs a different level of training. So it might be okay for some people to do e-learning and just have an awareness, but other groups of staff may need more intensive and face-to-face training. We try and incorporate training into our preceptorship programs, our new junior doctors induction, for example, our pharmacist training programs. So all of these different types of trainings, and make sure that when you're doing your training, you've got your service users involved and your ex-smokers involved in doing it. We also do regular training as part of our Recovery College programme, and that's co-produced, co-designed and co-delivered with the people who have been smokers and who are experts by experience. So this enriches the quality of the training that you are delivering. Thinking about the various different treatment pathways is really important, because the route into tobacco treatments for somebody who's using the IAP services, for example, in the community will be completely different to the treatment pathway for people who may be in the forensic services and maybe spending longer periods of time in hospital setting. So co-designing and delivering all of those treatment pathways is, again, another really important part of the jigsaw. Giving support and guidance for the policy implementation will require holding space for reflection on the policy, reviewing incidents and learning from them, looking at complaints and seeing what are the patterns, the themes that are emerging, and how can you try and prevent those things from repeatedly happening over and over again. Enhancing the infrastructure to support the implementation of the policy. This is really important, so we start to make it easier for people to implement the policy. One thing that we did was we changed our electronic patient record system so that we could embed that recording much easier, and also automate the referral system. And finally, in order to keep everyone engaged, you've got to give feedback. So feedback and data is powerful, and people can see what progress they made. They can compare themselves to other teams. They can be inspired and motivated to continue to do better when they see that the patients they've referred have succeeded to quit, and then that encourages them to continue referring more and more patients for treatment. Now, this will be familiar to all of you, I'm sure, because you know without any doubt that the 3 pillars of tobacco dependence treatment pathway, wherever it is, whether it's in a community setting or in a hospital setting, it's always got these ask, advice and act pillars as the foundation stones. So making sure that there is a system and a process in place so that everyone is asked their smoking status. We try to make sure that everyone's asked about their smoking immediately when they come into hospital, and that everyone's given tea and NRT on arrival to hospital. So that's quite a good way of perhaps remembering it. And then, of course, the important bit about offering support. The key thing here is that we are continuing to offer support to quit, rather than asking a smoker if they're interested in quitting, which will usually result in absolutely no, or telling somebody that they should stop, or they must stop, or they ought to stop, because we know all of these approaches will just result in rejection of our offer. Finally, we try to connect smokers with specialist trained advisors. And I'm going to show you in a moment how we've embedded that so that that's automated. The key thing then is that our specialist trained advisors are able to give medication or nicotine containing e-cigarettes to our adult patients together with intensive behavioural support. And then we give our smokers options, whether they want to quit completely in one go, whether they want to cut down, or whether they want to temporarily abstain. So let me just show you what happens when somebody is referred. So if I'm a nurse on a ward and I ask somebody if they smoke, they say yes. I give them the brief advice and tell them about the support that's available. And if they say yes, then I just tick those 3 boxes and automatically the referral is generated and it goes directly to the hospital advisors concerned. Now, if the patient is in the community, I just do the same thing. I ask those 3 questions, and if the patient consents to the referral automatically goes to the local stop smoking service. It's sorted by postcode because we provide services to lots of different London boroughs, so that's how it works. What it means is no phone calls, no referral forms, nothing gets lost. It goes in real time and there's no delay. So it's absolutely wonderful. I'd really encourage everyone to do it because it takes all the pain out of the referral process. The other restrictions that I think is important to remove is having control of data. So our data is visible to all clinicians across the organisation. And so I can click on in the morning and I can see where patients have been admitted, to which wards across the organisation, who's been screened, within what time frame, where the smokers are. I know all of that immediately at the touch of a button. We also tried to remove the restrictions to getting NRT, and the way we did this was we placed the NRT products on our homely remedy list. So the homely remedy list allows any registered nurse to administer those medication. It's got things like Senocot and Simple Linctus and paracetamol on there. So we've now got the NRT products as well. And that means if a smoker is admitted, once they've been identified, even before the doctor gets to the ward to clerk them in, we've already given them NRT. So there's absolutely no delay. The other thing that we've really worked hard to try and embed is routine carbon monoxide monitoring. The thing about carbon monoxide monitoring is if you're receiving smoking cessation support in a local stop smoking clinic, every time you see your advisor, you get your carbon monoxide level checked, and it's really motivating. We want to make sure that's the same experience for our smokers when they're in hospital. And so it's now part of the routine. If you're having your temperature, your blood pressure checked, then you get your carbon monoxide level checked at the same time. It was difficult getting that embedded, but once we said to our colleagues, if you had a diabetic patient, you definitely would make sure you're always checking on their blood sugar levels. So if you've got a smoker, then it makes sense that you need to be checking on their carbon monoxide level, because that's the thing that's going to really help them. In order to remove restrictions around e-cigarettes, we started to give free e-cigarettes out to all of our adult smokers if they wish to use them during the pandemic, and we've now continued to make that part of our normal routine practice. But in addition to that, we also now sell discounted e-cigarettes in all of our retail outlets. So wherever we've got a hospital shop, you can buy e-cigarettes there and you can buy them at a discount price. And this, again, it's removed another layer of restriction, another barrier. Most people who start to use e-cigarettes, they really want to continue to use them, but it can be hard to get their supplies. So having them available makes it easier. The other way we're trying to make it easier for people to use e-cigarettes is we're now installing smart charging units across the organisation. So this means there again, no barriers. You don't have to ask a nurse, can you recharge my e-cigarette for me? You've got access to a locker, you can charge it for yourself. So again, it's about making it as easy as possible for people not to smoke. I'm just going to say a few more things about that e-procurement, the procurement of the e-cigarettes. We wanted our patients to be really actively involved in this, so we asked them what was important to them when it came to purchasing an e-cigarette. And they said there were three things. They wanted the e-cigarettes to be acceptable to them, and by that they meant it had to be good at controlling those horrible nicotine withdrawal symptoms. Second thing that was really important, it had to be affordable. And finally, it had to be accessible to them. They didn't want us to give them an e-cigarette that they weren't going to be able to buy locally. They weren't going to be able to buy the refills locally or keep it maintained locally. And we asked our staff, the nurses and doctors that were working in the ward environments, what mattered to them about the e-cigarettes that patients were using on the wards. And for them, there were three S's. And they wanted to make sure the e-cigarettes patients were using were safe, that they wanted to be confident, that they knew how to support people to use them. And it was important to them that they were sustainable. So they wanted patients to be using rechargeable e-cigarettes, but also e-cigarettes that they were able to recycle some of the elements. So recycling of the batteries and recycling of the pod systems was something that really mattered a lot to the patient, to the staff. So with this framework in mind, we put out a specification on the NHS e-procurement framework. We got 8 companies to bid for the contract, and then we got our service users, smokers, to review the products and to look at what companies had to offer and to help us to make the decision about what was the best value for money, what was the best product, and what was the best contract we could have. And so we're now engaged in that contract, which involves the provision of the e-cigarettes every month, but also allows our service users to have discounted e-cigarettes for up to 18 months after their discharge. It was very important to us that we don't want people to start vaping and then to continue to vape forever. So what we have is an e-cigarette where we can titrate people down from 20 milligrams down to 0 milligrams, and we can continue to support them to stop smoking after they have left hospital, and hopefully they will have completed their smoke-free journey by 18 months. And we made all of that plan together with our patients and with our smokers. So we have a lot of listening forums with our patients, and they continue to shape the policy and to tell us what they want us to do next to help them. A very big part of our success, I think, has been removing the storage facilities for tobacco products. And this was one of the strong themes that came out of our listening exercises in 2016. Our patients told us that it was really impossible for them to avoid continuing to reach for their cigarettes if we still had them in the ward office. And here's a picture of Leon. Leon, I'm using this picture with his permission, and he's one of the people who has helped us a great deal to shape our policy, and who's, I think, given us the confidence to keep on making more and more changes. He said we needed to be better at helping people with their smoke-free leave and supporting them to avoid high-risk situations when they go out, and giving people more support to deal with cravings and better help to manage stress and boredom. And also to have that continued support after discharge. And that's why we've developed the e-cigarette program, which I've just told you about. Here's a summary of some of the changes that we've made with the help of our patients. So I've mentioned about stopping the storage of tobacco materials. I must say to you that that was quite a difficult thing to do. A lot of our colleagues had real concern about it. But one of the ways that we really helped was we compared tobacco products to alcohol, and we say to our colleagues in the wards, if you find alcohol in the ward, what would you do with it? And they always answer, well, I just throw it away. And so it's exactly the same thing now with tobacco materials. Of course, we always tell patients in advance, please don't bring tobacco into the ward. We remind them before they go out on their leave, please don't bring any tobacco materials back into the ward. If you do, we'll have to take them from you. We really don't want to do that. So with repeating of those messages over and over again, reminders in the community meetings, posters in key strategic places around the wards, lots of conversations to remind people, we don't find we get into much situations when we have to take tobacco materials from people at all now. I've mentioned already about supporting smoke-free leave and discharge, and also about regular CO monitoring. And finally, I want to mention about varenicline. Now, you probably know varenicline isn't available to us at the moment, but it is a really important part of our treatment pathway, and we're very much looking forward to when varenicline will be back on the menu again, and we really believe it offers a vital way out of smoking for many, many people in our services. So in 2019, we made some further changes. We changed our model from being a centralised model to being much more integrated into our local borough services. And that's when we started to provide support for people after discharge. And we were able to do that because we increased our team, and we've now got 14 tobacco dependence advisors working across the organisation. I've also mentioned already about the free e-cigarettes and refills just for our adult patients. I want to stress we absolutely don't support any of the young people receiving care to vape. Finally, for our young people, we have developed a bespoke training package for all of our CAMS colleagues, and we are doing a quality improvement project at the moment that involves trying to support the Smoke-Free Homes campaign. So that brings me to the end of what I wanted to say to you today. Thank you again for listening. I hope there's been something useful in there for you to take away. I think I will summarise by saying that without any doubt, the largest possible health gains for smokers can be achieved if they're able to quit smoking. And I hope there are some ideas here for you to take into your practice. So thank you again for listening, and goodbye from me.